Well, hello, everybody. My name is Don Self, and I'm going to kill the video for right now. So therefore, we can concentrate, instead of my ugly mug, we can concentrate on what it is I want to teach you. So stop video. Here we go. In the next 90 minutes, maybe I'll have it down a little bit lower than that, but around 90 minutes, I'm going to be teaching you what I believe that billing agencies should know based on 30 years in this business and working with physicians the way I have. I've owned a billing service myself back in the 90s. At the time, I was charging 12%, which was the highest of anyone I knew that was charging it, but I had people in line waiting to sign up with me. Finally, because my wife and I like to travel so much and I do not like to manage people, I ended up closing my billing service. I find that consulting is the area that I prefer to be in. Billing is great. I'm sure that folks that's out there doing it, which there's a lot of you doing it, about 46% of the people on this call right now own a billing service. About 24% work for a billing service. About 21% work as a billing person in medical practices. We have about 8% are consultants, and we even have about half a dozen office managers. Interestingly, more than half of the billing agencies out here are getting paid based off of a percentage of collections. So therefore, if I'm able to show you today how to increase your client's income, that in itself will help you increase your own income as well. So I'm going to go ahead and close the poll. That gives me what I wanted to know, information there. And then let's get started. Okay. Data is available out there, or data, however you pronounce it, is available out there to help you when you are trying to help your clients. Just the same way, I have the question answer period right here as well. And if you ask whatever questions you have at the end of the seminar, webinar, I will try to answer them for you. Moving along here. Here we go. Clinics need help. They don't know who to turn to. I mean, seriously, I get phone calls from doctors all the time. I got a phone call this past week from a doctor. You can still hear the music. I turned the music off, I thought. Let me see. I thought I paused it. Forgive me. And we don't want the music playing. Tell you what, let's kill the music, kill Pandora, boom. Sorry about that. Thank you for telling me, Georgette. Okay, but I had a doctor call me this last week saying that an insurance carrier was after him for almost $400,000. About a month ago, I got a phone call from a doctor that Medicare was after him for $700,000. I've got doctors, I know in a doctor in North Carolina that ended up spending more than $1 million on insurance carriers coming after them. Now, this is not an ERISA seminar. If you sat in on the ERISA seminar, you know how to be able to stop the insurance carriers from some of those. But sometimes if it's Medicare and we haven't been billing properly, we're going to have to pay the piper. And that means the doctors need to know what's going on. And you've got recovery audit contractors out there. You've got bounty hunters. You've got civil money penalties. All of this stuff has your doctors scared. They need your help. So what kind of help do they need? Because, I mean, again, you've got MACRA coming. You got Obamacare that's out there right now. Nobody knows what the future holds, or the one-payer system. If one guy gets in, he's sitting there saying that he can convert us over to a one-payer system. If Hillary gets in, I have no idea what she's going to do. If Trump gets in, I have no idea what he's going to do. Nobody knows the future. But these doctors are scared out there, I can tell you. Now, my question to you right now is, are you a billing agency, or are you just a claims filing agency? And there's a big difference right there between the two. Clinics don't need a claims filing agency. They can do that on their own. What they need are professionals who know how to get claims paid. And unfortunately, I've found in my experience out there, the majority of people that's in the business out there are just going after the low-hanging fruit. They're not working their butt off the way that they should. And if they were, the income would be a lot higher. For instance, some studies right here show 49% of hospital denials are appealed. That means 51% are not. Do the math right here. 72% of those appeals that's brought before an administrative law judge are overturned in favor of the hospital. That's almost 3 out of 4 times the hospitals win if they'll appeal it. So we've really got to make sure that we have someone that's out there willing to work these claims and willing to tell the doctor what they need to hear, tell the clinics what they need to hear, not just what they want to hear. There's a huge difference between the two. And if you see them billing something that's going to get them in trouble, tell them, stop them. Don't let them do that. And if that means you have to have the courage to walk away, walk away. About 1.5 years ago, I walked away from a $50,000 a month commission because I didn't feel like they were doing something right. That's $600,000 a year, and I walked away. Yes, I prayed about it. I talked to my wife about it before I did it, but it was the right thing to do. The money should not be a driving force for you when it comes to doing what's right or wrong. And don't let the same thing, don't let the doctors convince you that you have to bill something that you know better. It's better for them to know now than later to get a $400,000 bill along with penalties and interest and threats. I know one doctor in Georgia who had basically the part of the agreement with Medicare and the government. He's no longer allowed to have his wife work in the practice or be in the practice or have anything to do with the practice. They take this kind of stuff serious. So they really need your help on these kind of things. And I know I'm preaching a little bit, but they expect you to be honest and truthful with them. Sometimes, even if they don't want you to be, they need you to be. They don't need yes people saying, yes, you can do this. Yes, you can do that. They get enough of that from from salespeople coming in the door all the time saying, here, you need to buy this thing right here. I had one doctor ask me this week he was in New Mexico. He said, Don, I got this company out there saying that I can do this, this, and this, and this, 4 different things with this one piece of equipment. What do you think? I did a little bit of research. I said, yeah, but they may say you can, but it sure looks like this is going to be a violation of LCDs on this thing. They need somebody who's going to be helping them to keep them from committing fraud. They see too much dishonesty everywhere else, everywhere in our government, from the tax, from CMS, from all the scandals that's out there. They're being lied to, and they don't need you lying to them. They need you to tell them the truth. They need to count on you. And I know I'm preaching right here, but some people's going to lie on purpose, okay? For instance, let me see. Here we go. If you like your plan, your doctor, your hospital, you can keep it. Well, that's obviously, and it was obvious to anybody who read all 2,117 pages of it, okay? During my term in the U.S. Congress, I took the initiative to create the internet. Let me see. He served in Congress in 86, and the internet was created in 79. And so he didn't have a flux capacitor. That was obviously a lie. And that was obvious because he knew it was a lie. Some lie as a result of stupidity. The streets are safe in Philadelphia. It's only the people who make them unsafe. The ex-police chief and mayor of Philadelphia. Seriously? Well, how about this one? I haven't committed a crime. What I did was fail to comply with the law. Ex-New York City mayor right here. Some lie, continue to lie from accident. If you forward this email in the next 10 minutes to everyone you know, Bill Gates will give you a free computer. I've got a father-in-law who forwards me everything he gets via email or Facebook. That's like this right here. And he believes it, bless his heart. And then there's others out there, they believe, 2012 is going to be the end of the world. Y2K is going to be the end of the world. This hoax, that hoax. You got to be careful out there. Not everything, you don't know who to believe anymore. I mean, trust me, we'll pass this bill and afterwards we'll read it. That idiot. Or you got all these others out there. You got to be real careful out here. You can't trust what they say, even if they're in high public office. More and more of our imports come from overseas. Come on, George. Seriously? Imports from overseas? Duh. Well, how about this one? If we do everything right, if we do it with absolute certainty, there's still a 30% chance we're going to get it wrong. What is it about these people that these presidents put in position as vice president? I mean, let's go back to potato. We've got just, history of idiots. If you don't count the killings, Washington, D.C. has a very low crime rate. Ex-mayor of Washington, D.C. Well, here's this one. This is a Texan. She's down in Houston, Texas. She's a U.S. representative. One of the dumbest people on the face of this earth. Did the Mars rover take any pictures of the flag left there by Armstrong? Seriously, people. Okay, let's go ahead and get down to the point right here. How can I help you help your clients? Hopefully I've got your attention by now. I schedule 1-hour Zoom meetings with doctors, the manager, and the billers all the time. And that's what I'm going to do, is show you today what I do on that 1 hour with them. And therefore, you can learn what you need to be doing with your client, or whether or not you want me to do it with your client. By the way, if the doctor's not willing to be in a meeting, these are mine. Because I'm going to ask the doctor specific medical questions. I'm going to ask the office manager policy questions, and I'm going to ask the billing person that's on the call billing history questions of how they've been billing for something. And then I'm going to show them their own historical data, billing data, because I have it. I have it from every doctor in the country, and I'll go over that detail. Now, sometimes the doctors, before we do this, will send me, or the staff will send me, a procedure code frequency report showing me all the codes they've billed out year to date. That's great. Then I can see it on not just Medicare, but everybody else. Sometimes they don't know me whenever we first do these phone calls, so I end up having to rely on the Medicare data. And I have the data on every doctor in the country from what they billed from 2012, 2013, and 2014 on this very same computer I'm looking at right now. And this covers what they did on Medicare Part B, traditional Medicare. It doesn't show what they did on Advantage or Part C plans. And then I'm going to educate the physician, the manager, and the biller. And trust me when I say they need it, and they do respect it. This right here builds trust in them. And this is what you should be doing as a billing agency or a billing manager with the doctors. Show them, educate them. And by the way, almost every practice management system will give me a procedure code frequency report. Some companies, programs out there, they call it something different. Whatever they call it, you get the data right here that's showing every CPT code that they build, and I like to have it from year to date. And you can specify on the program what from and to date on these things. And it'll show their charges, the payments, the adjustments, and how many units. I don't care about the adjustments. I don't care about the net effect or percentage of net effect. There's a lot of people who sit there and they'll try to make a living out of, well, if you're not hitting an 86% collection ratio, then you're not doing your job. Or I hit a 95% collection ratio every month. Whoopee. That means absolutely nothing, because you might have set your fees all the way down to what you believe the Medicare allowed amount is, or what the carrier says the allowed amount is. But those things change. For instance, the Medicare allowed amount changes 4 times a year. At the beginning of the year, and then each quarter, you get Medicare Economic Index updates. And Medicare doesn't always tell you when they're doing that. And if you're still charging what you think is Medicare's allowed amount, you might be undercharging. In fact, in every single office that I've done an analysis on in the last 30 years, well, let me put it this way, not full 30 years. Since 1991, when we went to the RBS RVU system, and all physicians, regardless of specialty, in a locality are paid the same by Medicare, I have in every office that I've done this with since 1991, when we adopted that system, I found that the practices were undercharging and costing themselves money on some things because the doctors were afraid of adjustments, or the billing manager was afraid to explain to the doctor what adjustments are. So that numbers over there might mean nothing to me. The adjustments mean nothing. The units is what I'm looking at. How many times I built out each code? By looking at this right here, I'm able to tell all kinds of things. And by the way, if you ever send me one, send it to me sorted numerically, not alphabetically. Because I can look at this right here and see, well, 99201, this practice did 1, 13 99202s, 576 3s, 19 level 4s, and no level 5s. Interesting. No level 5s on established patients. I look down here and I find that they're doing a lot of preventive medicine. I don't see any hospital admits. I don't see any hospital visits. See, this particular practice did 3,127 injections. This was a busy practice, obviously, right here, a multi-provider practice. I see that they did 4 annual wellness visits during this time frame right here. So this is what helps me, like a CBC would help a doctor. This is what helps me. And like I said, I already have the data. I downloaded the data from Medicare on all the 2014 data. This just gives you an example right here. I have this on every doctor in the country, and it shows me what specialty they are, how many HCPCS codes they billed, the total number of services they billed out, how many patients. Tells me the total charges, total allowed, total pay, and then I break that down myself. And it tells me a lot more information. I'll show you a little bit later. But by looking at this right here, you can spot all kinds of things. And this is something, to me, as a billing agency, you should be doing on your own clients to find out whether or not your practice is flagging audits, whether they're undercoding, whether they're missing charges, etc. And if you don't feel comfortable doing it on your own client, or you don't feel comfortable chastising your own client, I don't mind doing it. Just because someone has a MD or DO after their name, that does not mean that I'm not going to tell them the truth. I'm going to be just the same, as honest with them as I am with you right now. So what is it we're looking for whenever you're looking at these kinds of information? Well, are they billing only the highest level codes? Occasionally I find that. In fact, you'll be surprised how often I find that. Occasionally I'll have a doctor tell me, well, I'm a specialist. I don't care what specialist. I'm a urologist. I'm a gastroenterologist. I'm a cardiovascular thoracic surgeon, or whatever. I don't care what specialty they are. And some of them have put the I in narcissist even twice. Regardless of what specialty they are, not every person they see is going to be the highest level code. Now, for instance, I did see one doctor who was internal medicine years ago over in Dallas. His first name was Jaime. And Dr. V was an HIV specialist. So even though Medicare did not have HIV specialty at that time, all they had him let down as an internal medicine, he was flagging audits constantly. And when he would get audited, the first thing he would do is call me. I would contact the carrier, Medicare, Blue Cross, both, and whoever's being auditing him, and I'd say, you guys understand, every patient he sees is HIV positive. That's what he specializes in. That's why his numbers are so much higher than the national average or the local average for his specialty. At that time, they did not have an HIV specialty code. Now, I'm going to show you a report on a doctor that saw 843 Medicare Part B patients in 2013, right here. This is him. I just opened up the letter C on my file footers because I have the doctors separated out by letter. And no, I'm not going to see any of my spreadsheets because this is something I spent hours and hours and hours doing, was taking mounds of data that was over 1 million rows of information and 72 columns of information and breaking it down into usable data. But I just went to the last letters of the letter C and found this Dr. Robert CZ something, I don't remember. And he's in Edison, New Jersey, and he's internal medicine, and this is what his billing shows me. Now, again, I have the data from 2012, 13, and 14. This data right here shows me that in 2014, he did 23 venipunctures on 13 patients. And his allowed amount average on that was $3. His average charge was $14.78, and his average payment at that time was $3 on that right there. And then we did the same thing right here for 96372, which is injections, etc. Let me make it a little bit easier for you to see bigger numbers right here. Now, when we're looking at this right here, I want to point out something right here. You'll notice he does not have any 99203, 99202. He's internal medicine. I know typically internal medicine, about 46% of the time, they're going to be level 4s. 44% of the visits from internal medicine, national average, are going to be level 3. And then it's going to vary, usually between 4 to 6% for level 5. Every one of his new patients was a level 4. In fact, he charged level 4 41 times on 40 patients on a new patient office visit code. And Medicare paid it because they didn't catch it. This happens a lot, by the way, but just keep in mind here, look at his established patients. 599 level 4s, 27 level 3s, 62 level 2s. Do you think he's skewing the way outside of the normal for utilization? Yeah, I do a comparison. Somebody's asking if this will be available later. No, but I will do this with your own doctor whenever you would like. But you need to understand, and again, I pulled this data up just on a doctor pulled it random. I don't know this Robert in Edison, New Jersey, but I have it on everybody, so therefore I'm able to pull it up. Notice this also right here. Every one of his initial hospital care visits, initial hospital care, every one of them was level 3. And if I was to talk to this doctor, if I was to call up this Robert something in Edison, New Jersey, I would sit there and say, okay, doctor, why are you charging every level a level 3? He'll sit there and say, because I spend this much time with him. I'm doing a 4-page initial visit or admit or whatever he wants to call it. And some people will still call these admits, even though they're just the first time he sees a patient. I mean, if you really look at this, interestingly enough, he charged out 223 initial visits. I mean, he charged out 558 on 446 patients, but yet he saw 557 patients in the hospital. How did those other patients, how did he see them without seeing them the first time? You see what I'm going? This guy probably still thinks that this code is only for his admits. And yes, I will show you how you can get this information from Medicare later, Katie. Okay, so looking at this right here, what else do we see right here? Other than the fact he's using nothing but high-level codes. Well, he's not the only one that does it. I just pulled up some doctors right here. Went in and grabbed them. Peter Mohai in Seattle, Washington. I don't know him. He's a rheumatologist. Notice he didn't bill out any level 3s or 2s. David Mall, I don't know him, in Derby, Connecticut. He's an endocrinologist. 960 of his was level 4. How does that compare to endocrinologist? Tell you what I will do is I will send everybody an average spreadsheet showing the average codes per usage for all of the doctors. And I will be able to do and send that to everybody that's on the call later. This guy right here, hematology oncology, Monty Metcalf. Again, I don't know Monty. Monty doesn't know I'm using this information right here. But notice this, 98% of his established patient office visits was level 4. Don't you know that he's been flagging audits? I was talking to a practice yesterday that sent me an email saying they're trying to find some ways to make some additional money right here, and the doctor's not sure he wants to do this or that. That I showed him how to make extra money. I said, you need to, because in 2013 you were flagging audits. And this year you're going to be audited based off what you did in 2013 because they're running 3 years behind. You're going to need a lot of money because he was one that was like this right here. Billed almost every visit. No, in fact, he did. He billed every visit as a level 4. He was a family physician. There's no doubt he's going to be audited. In less than half an hour, identified at least 40 physicians that had flagged an audit. That was only with the physicians of last name starting with M and N, and just scrolling down, not doing a complete analysis of these people, just looking at it, glancing at it. I can see these people were getting in trouble. And they're going to be audited. And it's a really good thing that I'm not a bounty hunter. I don't believe that in filing key TAMs unless you're one that's damaged. I mean, if you've been working for a company and the doctor says, hey, I want you to do this, and you sit there and say, no, I'm not going to do that, that's fraud, and you get fired because you refuse to do fraud, then yeah, you should be the one that's filing a key TAM. That's what the law is out there for you. It's not for bounty hunters. And by the way, it'd be interesting to know how many people are old enough on this call. They remember a TV show from the late 50s, early 60s with Steve McQueen as a bounty hunter. Josh, I don't remember Josh's last name, but it was a cool show. I loved his rifle. As you can tell, I like guns. Okay, same guy right here. This Robert guy in New Jersey. What do I notice right here? 38 injections. He charged 38 times to 14 patients for 96372. But no J codes. What is he putting into their veins when he injects them? Is it air? Is it Dr. Pepper? Or is the patient bringing their own drugs in? If some patients bring their own drugs in, if they bring their own drugs in, that's fine. I don't have a problem with that. But on the claim, you need to make sure you show what the J code is with a 1 penny charge. Therefore, Medicare knows that that administration was covered. And that's why a lot of carriers will tell you, show me the J code, and then just put either a 1 penny or 0 charge, depending on what your practice management system will use. Show them, give them a reason to pay. Do you notice anything odd right here? I just grabbed some Oz right here. This one in Nevada. Let me see, 138 new patient office visit, level 4 on 127 patients. And that's pretty common. I'm finding a lot of people, they still get confused about what's a new patient. I mean, there is probably not a month that goes by that I don't get an email from somebody or a phone call from somebody saying, I changed practices when I see my old patients under a new NPI number or a new tax ID number or a new whatever. Can I charge them as a new patient? No, you can't. And they need you to give them those answers. Don't let them charge a new patient if you know it's an established patient. Don't let them get in trouble. Okay, enough with me trying to scare the pants off of you right here. I'm going to show you how to increase the profits in the practices here. This is what I do with your clients. First, you really need to know the specialty you're dealing with so that you can identify what they're not billing for, what they should, etc. Years ago, I used to play tennis with this one doctor in my younger days before I got fat and old. And this one doctor was probably one of the best doctors his name was Clay Henderson. He was a family physician in Tyler, Texas, an MD. And he was probably one of the best at coding that I knew of physicians for family practice. And this was long before HIPAA. This was before 2003. And he said, Don, I'm really good at this. You wouldn't catch anything that I'm missing. I said, I'll make you a deal. I'll ride with you for one day. And everybody you see, I see. I'll be wearing a smock, and you just introduce me as your associate. And at the end of the day, we'll compare notes. And then I'll triple whatever it is I find in that one day that you missed, and that's what you owe me. He said, deal. So I went to the hospital with him, went to the office, went back to the hospital. Thankfully, we didn't go to the nursing home that day. Afterwards, we went to Red Lobster and sat there for 2 hours at Red Lobster, and I went over details with him. I found $508 he was missing in one day. And he was a lot better than most doctors I've seen. $508. So he wrote me a check for $1,524 that day. And that was about, was it 1996, 1997, something like that. And that was a lot of money for that one day. But think about what I made him if I increased his income $500 a day. And it's very easy to do. Now, some people are better at different specialties. I'm much better at primary care. If you'll give me a family, internal medicine, or geriatric doctor, I can probably do amazing with them. My average primary care client increases their income about $170,000 a year off of what I'm going to show you today. And you can do this with your client. So what you got to do is look at the procedures that the doctor's doing and then compare them with the billing records. What else do you look at? Well, on this same one that we looked at right here for this internal medicine doctor in New Jersey, he didn't bill out any procedures. There was no lesion destructions, but then he's internal medicine, so he probably wouldn't be doing those unless he's internal, has an internal shingle, internal name, internal board certified, but he's really doing family practice. And I see a lot of internal medicine doctors doing that. They're trying to see 25 or 30 patients a day. I'm sorry, it sounds like I'm judging, and then judge not lest ye be judged. But it seems to me like an internal medicine doctor seeing more than 18, 19, maximum 20 patients a day is probably trying to do more family practice than true internal medicine. Because true internal medicines, you're going to be pretty limited on what you can do in one day. This guy did not do any removal of impacted serum, but yet he saw how many Medicare patients? 847 Part B Medicare patients, and not even counting Part C. And you figure typically you're going to have about half as many in most places in the country, Part C's as you have in Part B's. Some places you have a lot more, like you get some places in California and Florida, and you'll have twice as many Part C's as you will Part B. But just for discussion's sake, he's got like 1,200 Medicare patients overall, and he didn't bill out any removal of impacted serum. And there's even new codes for that now this year when you have a nurse do it. He didn't bill out any joint injections or aspirations of joints, drawing the fluid off the joints. He didn't bill out any trigger points. He didn't bill out any EKGs. Now that's weird, really weird. But occasionally I'll find doctors that says, I didn't know I can get paid for EKGs. Or some doctors, they just don't do them because they don't want the liability involved with it. That could be with him, I don't know. He didn't bill out any spirometers. And yet 1 out of every 5 American adults have some kind of pulmonary dysfunction. I talked to a doctor on the phone yesterday, a local doctor that called me up. I've known him for years, him and his wife for probably 25 years. I asked him how they were doing. He said his wife's in the hospital. She's got pulmonary fibrosis. He said, I know you probably don't know what pulmonary fibrosis is. I said, boy, do I know what it is. My mom died from it, and all six of her siblings died from it. 7 people in one family died from pulmonary fibrosis. A lot of people have pulmonary problems. So why are the doctors not doing spirometers? That's a good question. I thought I killed the volume on that ringer. Forgive me. Okay, no ABIs. I mean, he sees how many diabetics, hypertensives, smokers, and no ABIs. That's weird. Okay, let's look at some of these things. Lesion destructions right here. I'll ask the doctor, how often do you destroy lesions off of somebody? And I don't care if it's keratosis or what, some kind of lesion. What are you removing? Well, pre-malignant lesions, most primary care doctors end up doing that from time to time. In a particular case, I looked at one of them. They did 22 charges for $17,000 and one charge for $17,003. If you're not that familiar with this code, you probably wouldn't notice something's wrong. Well, $17,000 is for the first lesion. $17,003 is for the second through the 14th lesion, and $17,004 is for 15 or more lesions taken off at one time. Now, you wouldn't know this, again, unless you have been around a lot of primary care doctors. But if you look at this billing average, but I've run the numbers here from dermatologists, since they do so many of these, it tells us that the average patient coming in to get lesions removed has 3.1 to 5.4 pre-malignant lesions when they get them removed. In this doctor's case, 22 times, he only removed one lesion. Now, I've got a feeling he's not giving his staff or the billing office or the billing agency all the information. This happens a lot, because if I had this doctor on the call, I'd probably ask him, Doctor, how often do you remove multiple lesions when you're going in there? He would probably tell me 2 out of 3 times I've removed multiple lesions. Well, 22 charges of one and one of the other, that doesn't equate out to, 2 out of 3. Joint injections. Notice something right here. Look at these numbers right here. We got 12 patients that received 15 charges of 20610. Yet we have 17 patients that received a corticosteroid. Well, how did you get that triamcinolone acetate into the patient if you didn't inject them? So there was 5 patients that did not get charged for the joint injection, putting that corticosteroid into them. This, again, is not uncommon. I see this kind of stuff a lot. Flu vaccines. We got 82 charges on this doctor right here. On 80 patients, he had 82 charges of the flu vaccine, but not one charge for code G0008. I know every once in a while I'll have somebody in a doctor's office. Sometimes it's even a certified coder. We'll come back and say, oh, we can't get paid for those in an office visit, so we bill the office visit. Yes, you can. Whoever tells you you cannot do something, make them prove it to you. This doctor just missed out on how much money, and you figure in New Jersey, it's, what is it, about $24, I believe it is, for code G0008. Medicare pays 100% of it. 82 times. Well, there's some money right there we're missing. Look at this right here. We've got over 600 charges of J codes right up here. Now look up here for the 96372. There was none. There was no 96372. It'd be right here between the AMSAR and the OMT, which, by the way, is OMT code. He billed the highest level, notice that, but no injection charges. So how are they getting the injectable into the patient? Make them swallow it, snort it, put it up the poop chute in the suppository, or what? I mean, that's a lot of money right here. If we're talking, 600 charges times, what is it, $23, $24 for a 96372? That adds up. Venipuncture. Notice this one. We got 174 venipuncture right here. And then go down here to 85025, you have 231. Well, venipuncture, a CBC is done when you're doing it with an auto-diff. You're doing it by drawing blood, not a finger stick. So why do we have 50 patients right here that wasn't charged for the venipuncture? This kind of adds up. Notice something else on this one too. This particular doctor right here has 1,410 Medicare patients. He only did 121 A1Cs, and you do an A1C, according to Medicare, 4 times a year, every quarter on every controlled diabetic. That's what Medicare's guidelines are in the very first PQRS. So if he's doing that 4 times a year, that means he only has 30 Medicare diabetics out of 1,410 Medicare patients. If I'm in a seminar, and I do a lot of seminars to doctors at the different conventions, for many, many years I spoke at just only, really, DO conventions in those practitioner conventions, office manager conventions. But there wasn't really any allopathic conventions, MDs. But just recently, I've started getting MDs contacting me and asking me to speak at theirs. And when I'm doing these things, I'll ask the doctors, let me see a show of hands. How many doctors in the room sees your diabetics every quarter and you run an A1C the way Medicare asks? By and large, at least 80% of the doctors raise their hands. And yet when I look at their numbers, I find, no, they're not. So this right here does make a difference in their practice. And no, I'm not, maybe you sit there and say, well, you're trying to tell a doctor how to practice medicine. I don't care. I'm showing them what Medicare says, Medicare expects on their patients. If whether the doctor does or not, it's going to be up to the doctor. But I'll wager most of your doctors think that they're doing their Medicare patients more often, or they don't know that Medicare wants this on every controlled diabetic every quarter and every uncontrolled diabetic every visit. That's per Medicare's guidelines. And you can find these on the PQRS, by the way. Notice the same one right here. We have 477 venipunctures right here, and not one blood test billed for. Not one. They're sending them all out. Why? Because the doctor thinks that they can't make money doing blood tests in the office. I mean, he's got at least 477 blood draws right here. And he's not even doing CBCs in his own office. Come on, losing a fortune of money right there. And they're probably complaining, well, between Obamacare and all these plans out here and Medicare's, I'm losing money. Well, you can complain all you want to, but if you're not going to get off your butt and do something about it, don't complain to me because I don't want to hear you. I'm not when the answers are so simple. I mean, they're out there if you just act. And that's what I tell the doctors. I don't want to hear it if you're not going to do something about it. Bitching about it doesn't help. Pneumonia vaccine. This guy has 11 patients got pneumonia vaccine administration right here. Yet the doctor, I mean, he gave a vaccine, but he did not charge any G0009 for the administration. So again, how is he getting that vaccine into the patient? This one right here, 9305, EKG tracing, 47 times on 40 patients in the office right there because it wasn't an EFA facility. Well, is the doctor not doing his own interps, or does he not realize that he can do his own interps? Or does he have a billing person that was practicing back in 1992 when Medicare said in 1992 they will only pay for with a technical charge of 9305? How up to date is their biller? Well, how up to date is their office manager that's been with the doctor for 30, 40 years? These are kind of things that you can spot by running these kinds of numbers right here. Talk about spirometry right here. This doctor right here did 33 spirometers and also did 22 airway inhalation treatments, but did not charge even once for 94060, which was a pre and post bronchospasm evaluation. I'm not even talking about a full PFT right here. Spirometries have their use on catching the mechanical problems with the lungs. Doesn't tell you anything about gas exchange. It doesn't tell you anything about differential. You can't diagnose pulmonary fibrosis with a spirometer. It's going to take a full PFT with oxygen saturation and gas exchange. But they're handy to have in there. But if we're going to be doing the spirometer, let's make sure we build the right code. Do you, as a billing agency, ask your doctor, are you doing pre and post, or are you doing only post? I mean, a single determination. Because there's a difference. Like in New Jersey, right here, it increases the reimbursement, not quite double, but probably 74% more. Look at this. The primary care doctor not doing any AWVs, no 93922 and 93923. Now, yet you look at these numbers right here. 1 in every 3 people with diabetes have peripheral arterial disease. 1 in every 4 black people over 50 have PAD. 1 in every 5 people over 50 have PAD. 1 in every 3 people with heart disease have PAD, according to the National Institute of Health. And look at this reimbursement, $89 and $140. And this doctor didn't do any of them. Now, this particular doctor did spirometry evaluation with bronchospasm eval. That's good. Doctor was doing NCVs. And I'm going to talk, and I'm not really going to go into great detail on the number of units, but I can tell you right now, if you're talking about physical medicine services, you're really limited to 1 every 15 minutes, regardless of what that salesperson says. I got a special webinar on my website about that. By the way, if you haven't been on my website, I think I've got like 12 free webinars on there right now that you can watch, all of them 10 to 12 minutes long. And some of the stuff I'm talking about on those issues as well. What about pro time? Here's one. Doctor billed out for 131 pro times to 28 patients. That's normal. If the patient came in, saw the doctor, did a pro time, we gave them the results, or we called them with results later, that would be great. That's what you'd expect. But is this one of those offices where the patient comes in and sees the nurse does a pro time, sees what the number is, and then following the doctor's orders says, the doctor wants me to go up or down on your dosage right here based on your numbers right here. That's a 99211. And if that's the case, and a lot of offices do it that way, why are we not billing out with a 99211 with it? Well, somebody told me you can't bill a pro time with a 99211. You can if you're doing a 99211. If all you're doing is drawing the blood, running the pro time, and then call the patient later with results, you're not doing a 99211, so don't bill it. But if you're giving the patient the results, then there's medical decision making right then on what's going to be happening with that patient, and you're telling that patient what the results are, why not bill a 99211? 131 times $20-something, or $20, I know it adds up. Initial hospital care. Okay, well, let's take a look at this one right here. What's interesting about this right here? Well, we did a hospital daily care on 37 patients, but we only did initial hospital care on 11. So how did you see the patient the second time you saw the patient unless you saw him the first time? Now, if this doctor was a part of a group practice and the other doctors in their group practice saw him, these numbers would not be bad to me at all. This was a solo doctor, by the way. So in a solo doctor, it's not going to happen like that. I mean, it's not very likely going to happen. Maybe the doctor had already had 26 patients in the hospital on January 1st, whenever it crossed over for this time frame right here. A lot of your doctors do not realize that the codes for initial hospital care changed back January of 2012, 4 years ago. You really need to make sure your doctors know this. They may still think that that's only for hospital admits, like what it was over 4 years ago. Hospital discharge. We have right here 33 charges for 99238 on 33 patients. Now, there are two things that are really happening here. One, the doctor doesn't keep track of the time that they're spending on the final visits with the patient, time spent with the family, time spent giving instructions to the nurses, time spent dictating to the hospital, or time spent coordinating care of the patient, writing prescriptions, or coordinating with home health or DME, etc. If you've got at least 31 minutes of that time on a hospital discharge day, then the doctor needs to be telling you billing service about 99239s. If you see all your doctors billing out as 99238, that's very rare. And it could be your doctor's in New York City, talks very fast, gets everything done, boom, 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 moves in, moves out. But if your doctor's from Alabama, Mississippi, Texas, Georgia, South Carolina, North Carolina, where they talk slow, chances are they're spending 31 minutes or longer on some of them. What's missing right here in this particular practice right here? Well, interestingly, we have new office visits, and we have some established and some hospital discharge days. Critical care first hour, no second hours. Okay, we had 699 Medicare patients. What is it that's common about Medicare patients? Medicare patients many times are going to need home health to come see them. I don't see any home health certifications or recertifications billed here. None. Why? I mean, we're talking about code GO179 and GO180. Why none of them billed? We're talking about some money here too. I went to my program, my coding advisor, and I pulled it up, GO180. It's got a Medicare allowed amount of $60.33. After the sequester, Medicare's check is going to be $47.30 on each one of those. And that was for, this year, 5/10, well, that was today, in fact, when I ran that number this morning, in fact. So it kind of adds up. Now, let's talk about this. I'll ask the doctor, how many initial certifications do you sign a week? How many research? On average, I find my family docs and my internal medicine doctors typically signing about 3 initial certs and 3 recerts a week on average. If you average it out over the month, when the home health agencies bring in the forms and ask the doctors to sign these things right here. So 3 and 3. That can add up to a lot of money. So we're looking at these right here. Too many managers and billers confuse GO181, which is care plan oversight, which requires 30 calendar minutes a month documented day by day, minute by minute of what was done. And I'm not talking about that. This is totally different. This is for signing the home health cert saying this patient qualifies for home health. The doctor assumes a certain liability and you got to keep a copy. Don't let the GO181 confuse you, because that's a very costly mistake right here that practices make. And it's not just the practices. Sometimes it's the billing people, and sometimes it's certified coders. And I'm not picking on the AAPC or AHEMA folks, but I'm telling you, just because you have a certified coder in there doesn't mean they're capturing all this stuff. Because I'd say at least a third of the practices where I'm spotting these kind of things have a certified coder in there. And they could just be overworked. I'm not picking on them. But just because they have a certified coder in there does not mean that they're doing everything right. We need to be watching this kind of stuff right here. Contact your local, and maybe you lost this money, maybe you didn't. Contact your local home health agency that the doctor does business with. Have them put a copy of every recert the past 12 months in a PDF on a thumb drive. That's real simple, because that's the only documentation you have to have is a signed form the doctor kept, and keep that. No, you don't have to go back in and put it into the certified record or into their progress note, et cetera. As long as you have it, so if the doctor gets audited, you can say, here is a CD with every one of them from that doctor, from that patient. Now, if we're doing 3 a week, certs and 3 recerts a week, that's $16,000 you just recovered. Maybe that's not a lot of money to you, but maybe if you're making, 8%, 6, 7%, a lot. It depends on what you're making right there on your patients. On your doctor. That can add up to more money in your pocket as well. But it's your doctor's money, and this is what you should be doing, regardless of whether you get paid extra for it or not. You should be doing the very best job you can for your doctors, because the doctors don't know they're missing these kind of things. What else is missing right here? Well, the same one we looked at right here had 15 annual wellness visits. That's the PPPS subsequent visit. 15 out of 847 Medicare patients. This number in a year's time should be close to 847. Now, that's a lot of money we're talking about right here. 847 patients and no alcohol screens being done. Medicare wants that done yearly. Cognitive testing, Medicare wants that. That's part of the annual wellness visit. Or depression screens, none. This practice is missing a little bit of money. And that's just Medicare 847 Part B. How many Part Cs? Let's say they've got 50% of their Part Bs or Part Cs. That's about 1,200 Medicare patients a year, and we're missing out on those kind of things. What else is missing right here? We've got, 881 hospital visits, 264 discharges, and not one critical care charge. A lot of your doctors think critical care can only be done in the ICU. Wrong. Critical care can be done in the office, done in the hospital, in the ER, at Walmart. I don't care where. It's not a place of service. It's what your doctor's doing. That's why you got to know your specialty. And you can't be afraid to ask your doctor questions right here, because these doctors need to be challenged. They need that. They need to learn. You need to learn. Okay, so what do I do whenever I get your doctor on the phone call with me? First thing is I'm going to ask you doctor-specific questions. Like this particular doctor, I looked at in New Jersey. He was internal medicine, solo practitioner. I know I did a search on his address. And one address, one location. Let's say this doctor was referred to me by XYZ billing agency. Internal medicine, he's open 4.5 days a week. He takes off at noon on Wednesday, for instance. That's what it showed on his website. 18 patients a day typically. 684 Part B patients, so I don't need to know a percentage. And I'm going to ask the doctor questions about diabetes and hypertension and GERD and stuff. Wasn't doing any diagnostics, was not billing out any annual wellness visits. If I called the office and asked them, they're using centricity, this particular office, it doesn't matter. But these are the questions I need to know when I'm doing the analysis with your client. These are the questions I'm going to ask you, doctor, while you're on the call with me and the doctor's on the call. Now, they can guess at the number of diabetics, or hypertensives, et cetera, but if they don't know, that's okay. I can pull it up and see based off of Medicare's numbers right here, because Medicare tells me. Like, for instance, one of these doctors had 8% of his patients had AFib, 14% Alzheimer's or some kind of dementia, 7% asthma, 8% cancer, CHF. He had 515 females, 344 male patients that he saw that year, 498 white, 31 black, 263 Asian. The information that I get off of Medicare's reports is amazing on these doctors. And I see this particular doctor had 47% of his patients that he saw had diabetes, 65% hyperlipidemia, 75% hypertension, 35% depression, etc. The numbers are out there. So I'm going to ask the doctor, and if the doctor knows, great. And if not, I'll just go to Medicare's numbers, because typically what they're doing with Medicare is what they're doing with non-Medicare. And the numbers are there. So I'll ask you, doctor, do you agree with these numbers from the National Institute of Health about 1 in every 3 people with diabetes, 1 in 4 people? And if the doctor says yes, which they almost always do, sometimes I'll say it's a little light, I'll ask them, does your staff or do you regularly ask the patient these questions right here in purple? And if not, why not have your MA do it when they're in there checking the vitals? This can be counted right here towards the review of systems right here. This right here can be very helpful, regardless on the coding side, but just on helping you do a better job on the patients. And whenever I ask the doctors what percentage of their patients, if they ask them that's diabetic, hypertensive, or smokers, would they say yes to, almost every one of my doctors will say 75% to 50%. So let's say 50%, just for the sake of discussion right here. I'll ask the doctors, are they familiar with Medicare's PQRS on the ABI, where Medicare is saying over the age of 40 years old, 30% of people with diabetes have loss of sensation. And patients right here with diabetes are having foot problems such as amputations. This blows my mind. In people with diabetes, 22.8% have foot problems such as amputations and numbness. An amputation is a foot problem? To me, that's a hell of a lot more than just a foot problem. I think they're minimizing it right here. I mean, it's not just the old people. My wife's cousin, 52 years old, had to have his right foot taken off because some idiot doctor out there in Midland, Texas, never checked his feet, even though he had been diabetic for 10 years. Never checked his feet until he finally does, and they're gangrenous, and now it's time to take the foot off. That's incompetence. I do not suffer fools lightly. Forgive me. And then she said, well, you can't say that. You're not a doctor. I don't give a dang if I'm a doctor or not. If a doctor's doing the wrong thing, they need to be told they're doing the wrong thing. Forgive me. I get upset about this because I just hate seeing him having to hobble around like that because of some incompetence. Let's go back to this. What diagnosis do you use? A lot of people don't know that the diagnosis as a result of the claim, according to Medicare, CMS 30.61 said for outpatient encounters for diagnostic tests, has been interpreted by a physician and final reports available at the time of coding. Code any confirmed or definitive diagnosis is documented in the interpretation. And you don't code related signs and symptoms as additional diagnosis. You just use the one that comes back and shows this patient has atherosclerosis or has occlusion or whatever it is. So which diagnoses do you use? Well, you obviously need to check your LCDs for your state because they can be varied from one state to another right here. Sometimes billing people tell me, I bill for doctors in different states. Is there an easy place to find them? There is. I created this program called Coding Advisor with the help of a fella in New Jersey, and we've gone through and spent a lot of time for the last 7 years fine-tuning this right here, because it used to be I'd have to go to one place to find a CPT code, somewhere else to find the LCD, another place to find the CCI edit, another place to find Medicare's allowed amount, another place to find out what the global fee period is. I've got all this put into one place right here. And I primarily did it, honestly, so that I would have this available myself. Well, because I've done this right here, and I then gone through and put in notes literally on hundreds of codes, billing advice on when the doctor can and cannot bill for this, or what code to use for this, or what modifier to use for that. I now have it out there where I have, I don't know how many hundreds of subscribers that pay $2.99 a year for this. So therefore, they have all this data available. Now, I'm not telling you need to go do that as long as you have availability to get this data somewhere. But if you wanted to, you can try this for 1 week for an absolutely free trial. Go over to my website, donself.com, and click where it says Coding Advisor, and then that's going to take you to a page here. And then you'll click I want a free trial, and then put in when you want your free demo, because in order to get a free trial, we're going to schedule 10 minutes to go show you exactly how to use the program the best way, and it's free. You don't need a credit card, and try it for 1 week. Now, using my program right here, I found out that New Jersey, I went to look up what the LCD is for the ABI in New Jersey. And I find New Jersey has an ABI, but it's only for IDTFs, not for physician offices. That means if there's no LCD, no NCD, which there's not an NCD on ABIs, since there's no LCD in New Jersey, as there is in New Hampshire and Nevada and Nebraska and New York, etc., because I just grabbed this one area right here to copy paste or print screen, that means we go back to medical necessity. So the doctor is going to do it on whenever the doctor believes it's medically necessary. Again, that's going to be patients with diabetes and hypertension and other things like that. So let's run some numbers for this particular doctor. Seeing 19 patients a day, 47% have diabetes. That's about 9 patients a day. I didn't even ask about the others yet, just diabetics. He sees his diabetics quarterly, we'll assume. So you're not going to run an ABI every time on a patient. So if we're seeing 9 patients a day over 4 quarters, that equals about 2 patients a day that would qualify for it. And he said about half of his patients would say yes to having some kind of neuropathy problems. That would be 1 ABI a day. And again, that's not even asking yet about the other, the smokers, or the hypertensives, or the atherosclerosis patients, or the patients with chronic ulcers on their legs, or the patients with pain in the limbs. These are all under national coverage, typical diagnoses you would find for an ABI. There's 2 CPT codes for an ABI. You got 93922 for a basic and 93923 for a segmental. Notice the reimbursement difference, about 50% more. This is what I'm doing with your doctor when I'm talking to him. I'll show the doctor my own screen right here. And the doctor will see if I put in 1 a day, and an ABI that would run about $7,600 something that would tie into the medical records program and download a printable bidirectional waveform, which is required if you're going to bill it, was to put that on a 5-year lease, would be about $159, and I show that only for ROI. Most doctors don't lease it. They just write a check or give me a credit card. Medicare's allowed amount, average in the country for the 2 codes, because sometimes it'll be a basic, sometimes it'll be a segmental, it's $134. If you did that right there, 1 a day, and this doctor's open 4.5 days a week, that's about $2,500 a month, minus the cost of doing it. It's about $2,300 a month net, or $28,000 a year. And it takes a doctor 1.2 tests a month to break even on their investment. And if they took the money that came in from this right here and paid off their note or paid back their credit card or whatever, they'd pay it off in 3 months. That's about a 375% annual return on investment, which is better than the 7% they might get from mutual funds. Now, what about annual wellness visits? Regardless, a lot of you doctors are not doing the annual wellness visits. They think it takes up, they think that they have to do it themselves, or they think that it's going to take a lot more time, or whatever. I don't know why they're not doing it. I really don't. Let's look at annual wellness visits. This particular doctor in New Jersey we looked at has 843 Medicare lives. Again, this is only Part B. I don't know how many Part C he's got. But if we divide that by 12, that's 70 annual wellness visits a month, or 3.6 he should be doing if he's open 4.5 days a week, which is 19.5 days a month. So that's 3.6. So how much money do you think this doctor would be making if they did annual wellness visits in their practice? Take a guess right now. Well, we know that Medicare's allowed amount, where this guy is in New Jersey. He's in northern New Jersey, because New Jersey is broken into 2, northern and west, is $191.26 for the first AWV and $130.10 for every one of them after that, giving you an average of $160. But you got to educate the doctor. These will be done by the nurse in most states. And if the doctor doesn't want to hire a nurse, I'll hire a nurse and put them into practice right here, and the doctor will pay me. And yet the doctor will still be getting it done. In some states, you can even do it with an MA. A couple of different Medicare MACs have said MAs can do it. It's not a physician service. How do you know it's not a physician service, Don? Anytime Medicare pays 100% of something, Medicare expects it to be done by a nurse, an MA, or somebody else in the practice. That's like the Venipuncture, paid 100%. G0008, G0009, paid 100%. The depression screening, the alcohol screening, those are paid 100%. If it's paid 100%, it's not a physician service. That's an easy way to remember it. Okay, what is the annual wellness visit? First off, let's look at it. It's not an annual physical. And that's something your doctors don't know. Your patients do not know that. And your doctors do not know it. Medicare has never paid for an annual physical. As far as I know, they do not now. I don't know if they ever will. Record keeping is what annual wellness visit is. You update the individual's medical family history. You get a current list of the medical providers and suppliers and all prescribed meds. You then record their vitals along with the BMI. You detect any cognitive impairment. There's a couple of different ways of doing that. I'm going to show you those. You update, establish a screening schedule. So the nurse should sit down with the doctor before ever doing this. Or if I'm putting in my annual wellness visit person in there to do it, I'm going to have your doctor, or even my program, I'm going to have your doctor sit down with me and on a phone call, and I'm going to say to the doctor, how often do you want a colonoscopy if the patient is 65 with these problems, or would you rather have a sigmoidoscopy? How often do you want a bone density? How often do you want this test or that test, et cetera? Go down the list based upon what it is the Medicare guidelines are. And I'll show the doctor the guidelines if the doctor wants to know what Medicare recommends. And therefore, when the patient comes in, you're not having to bother the doctor because you've already got the set of guidelines and protocols set down for the nurse to use. This makes sense. Doctors don't want to spend their time doing this, so you really need to make sure you have protocols set up on this, and that's what I do. You furnish personalized health advice and appropriate referrals. So, doctor, if you have a 350-pound patient come in with an A1C of 11, do you want that patient sent to an endocrinologist? Do you want them sent to a vascular surgeon? Do you want them sent to the, caretaker? What do you want done with this patient? Because you need to give me your guidelines so then I can follow it. Now, that's all there is to it, to an annual wellness visit. Oh, the patient does have to do a health risk assessment form first, but let the patient do that. You can mail it to the patient. They can do it online, or if you want to, in a lot of my practices, the staff will call, and this doesn't have to be a nurse, or it can be somebody without any letters after the name, can call the patient and ask them the questions on the health risk assessment form, and then have that so when the patient comes in, we do the vitals, we give them their referral, we give them the updated screening schedule, we do the cognitive tests and send them on their way. And now then you're looking at a whole lot of money, by the way. But let's go talk about cognitive testing right here. What is cognitive testing? What is your name? Well, what did you have for breakfast today? Who is the current president? If they say Truman, you know what, we're not going in that direction. What was the first car you drove? What year is it? Who was the first person you ever kissed? Please draw a clock for me and show me what the hands on the clock look like at 4:30. Do you realize in 30, 40 years from now, when the young people, the millennials, getting into the old age, my age, ask them to draw a clock, and they're going to draw a digital clock. By the way, you do the annual wellness visit cognitive test this way, and it's free. You don't get the bill for it. There's a better way, though, that's not going to depend upon the skill of the nurse or the mood of your nurse when the patient's being seen. And that is you have the patient sit down in front of a computer right here and take a test that's designed for them. That's kind of cognitive testing I do, and I set up a lot of my clients for. Give an example right here. This is a patient right here. Oh, I'll go back to it, I'm sorry. This patient right here, we take a little 12-minute test. Let me see if I can sit there and pop it up right now. Notice this patient. He draws the computer all the way over here, moves it down there to the trash can, and then his computer disappears. Well, Linda, help. These things right here I'm talking about, though, are designed for Medicare patients. If you're going to do cognitive testing this way, you've got two CPT codes you can bill, 96103 and 96120 for administration of computerized neuropsychological and psychological tests. Now, by doing it that way, you get the bill out, and you have a Medicare allowed amount of $78.21 in this part of New Jersey where this doctor is. That test costs you $25. There's about 7 different companies out there that offer these kinds of tests. I use one I've been using for years called Cognitrax. Been very pleased with them. And I train your staff on how to use them if they use me on this. It gives you a profit margin of about $53 per patient. If this doctor has 847 Medicare patients and you multiply that times the profit, well, there's an extra $45,000 a year just on the cognitive testing. Net profit on this thing right here. And you're making 6% or 8% or what is it you're making because you get to bill this out? This kind of stuff adds up for your doctors too. Show me the money. Okay, let's look at it. Let's say we have 843 Medicare annual wellness visits. And we divide that out over 12 months and then 19.5 days. That equals out to about 3.6 annual wellness visits a day. Well, just on these average between the two codes, the GO438 and GO439, that gives you an average of $578 a there. And let's say you're using my AWV solutions, or your doctor is using my AWV solutions program. That's where the nurse carries around a tablet or laptop, does it all on there, hits print, and prints out exactly what Medicare wants the patient to get because they have to get a printed report before they leave. Otherwise, it's not an annual wellness visit. Well, my doctors pay this company $19.90 for that. So that's a deduction. But then we also get the bill out for the alcohol. Go back. I didn't mean to click on that. You get the bill out for the GO442 for the alcohol misuse screen by asking the patient 5 questions on alcohol misuse. That can be done over the phone or in person. Because as of January of last year, we get to add that we get to do that, as telemarketing. GO444, that's the depression screening. GO446, cardio disease behavior therapy. That's going over the results with the patient. This is the diet the doctor wants you on. This is the exercise the patient doctor wants you on, etc. All of this adds up to about $213,000 a year. Now, some of you sit and say, wait a minute, none of my clients are primary care. What else can my doctors do if I'm not dealing with primary care? So in this particular case, this doctor was primary care, $213,000 a year. That's kind of substantial right there. What about chronic care management? I'm setting up a pain management doctor out in California right now with chronic care management. Why? Because the other doctors in their town that's primary care aren't doing them. And chronic care management can be done by any specialty. Medicare designed this for the primary care doctors. But since primary care doctors, a lot of them are sitting on their thumbs twiddling, doing nothing on this right here, Medicare came across last year and said, guess what? You can do it any specialty you can. Now, some doctors tell me, we already do that. We do it on about 10 patients a month. Let me see. You have 843 Medicare Part B patients. If 80% of your Medicare Part B patients qualify, when that's typically 80 of your Medicare patients qualify, that's 674 patients a month that should be getting it, and you're doing it on 10? Well, I don't want to have to change computer systems. I don't want to have to hire any staff. Can't my nurses do it? Well, sure, if your nurse doesn't mind working 24/7 because there's a requirement in here that the patient can reach somebody that's on their care plan, a medical professional, not an answering service, a medical professional that's familiar with their care plan 24/7. And you don't mind giving access to your computer to every other doctor in town because that's part of it as well, without breaking HIPAA rules, because that's a requirement. Well, what exactly does this require? Let's go over it. In order to do chronic care management, and I've got cardiologists doing this right here. I've got a pain management doctor. I'm getting set up to do it. Most of my clients doing this have been primary care. I encourage my primary care doctors to do it. But you can take a horse to water, but you can't make them eat their vegetables. So no matter how much I preach at some of these primary care doctors, I cannot get them off their butt to do this. 2 or more chronic conditions expected to last 12 months or until death. And by the way, this is going to make the money I was talking about earlier seem small. This is that much money. Patient at significant risk of death, acute exacerbation or decompensation or functional decline. That's your diabetics, your hypertensive, CKDs, COPDs, all of those right there. A lot of your patients have these things right here. More than 80%, but around an average of 80% sign up for it. And it can, like I said, be billed and performed by any specialty. You must have a signed consent form by the patient and must have a billable face-to-face with the provider prior to the program, because the doctor needs to explain to the patient. They can hand the patient a form when they arrive in the reception area. This is what I do in most of my offices, my clients. And it explains, why is it I want you to get the chronic care management? Why does Medicare want you to get it? Why do I want you to get it? And explain it to the patient. So therefore, the doctor's not having to go over everything back there again. Just hit the high points. What does this actually require? All community providers must have access to the patient's care plan electronically, not via fax. That means, say you're the pain management doc, the patient's family doc, internal medicine, the nephrologist, or gastroenterologist, or the endocrinologist, all their ologists need access to this right here. This turns off a lot of doctors. This is why I told the doctors, and some of you that's watching this right now, February of last year, I came out across and said, don't worry about CCM, it's not feasible. It wasn't until after that that Medicare came out and said, management companies can do this for you and doctors can use a management company, that I finally jumped on board and say, now it's feasible, now it's profitable, because you don't have to worry about changing your computer system. Because most of your doctors have what's called a provider-centric program. This one has to be a patient-centric. Patient, family, and relevant caregivers must have 24/7 access to a clinical person involved in the care plan. They must have electronic access, a paper copy of the comprehensive care plan every time it changes. They must have medication reconciliation from all providers, not just your doctor, but the endocrinologist, ortho, the cardio, the dermatologist, anything else, any other doctor that's seeing this patient, you've got to have in the care plan what drugs are getting. So you really don't want your staff doing it. That's why this makes sense to let CareSync and me do this, and our nurses will be calling the patient's doctors and getting all this information and putting it into a system that your doctor will have access to. They must spend at least 20 calendar minutes per month of non-face-to-face time, and start-stop time is required. That doesn't mean you have to spend 20 minutes on the phone with your patient. Some of this right here can be your patient. Some of this right here you're on the phone. Some of this right here can be you spent 20 minutes reconciling their drugs or talking to other doctors and getting the information. It must include relevant input from all home and community-based clinical service providers, the home health, the DME that the patient's getting, etc. All of this has to be done. And it must be provided by provider service using an EHR system certified in current and previous billable calendar year. The system that we're using at CareSync is that. I know it sounds like a sales pitch, but we're talking about 847 Medicare patients. How many nurses, how many nurses will it take to document? 20 minutes a month? You figure typically it takes one nurse for every 200 to 225 patients. You need 4 in order to do that. But instead of hiring 4 nurses and having them work weekends, holidays, at night, 24/7, you're going to have covered, use our system that's EMR patient-centric, and you don't have to worry about changing EMR providers, because CareSync will be doing this. CareSync's the one that does this with more doctors in the country than anybody else. That's why I'm allowing this. That's why I'm bringing this up and telling you about this right here, because this right here works. Medicare Learning Network came across and said, even though we've always known Medicare, you can't do pass-through billing, the Medicare came across, CMS has said, you can do this. This is the only service that you can do pass-through billing. In other words, you pay a management company, and the management company does the service, and your doctor gets to make the money. Now, is it really worth it? What kind of money are we talking about right here? Well, the code is 99490. On this doctor here in New Jersey, it's 4501 is the allowed amount. He'd be paying CareSync $28 a patient to do this every single month. His profit is $17 without his staff having to do anything other than the billing. That's your job, because you're the billing agency. And we know that 64% of Medicare patients have a secondary supplement on average. In some practices that I've talked to, every patient does, because that's what they require before they'll take on the patient. But some do not. That's why we get an average of 64%. Let's say your doctor doesn't. Your doctor's in a state where, like in Texas, after Medicare pays, Medicaid doesn't if the deductible and deductible has been met for the year. Well, in that case, all your doctor is going to get is 80% of that 45, so your doctor get $36. That means your net profit is still $8. There's no way for your doctor to lose money on this kind of stuff right here. And 80% of Medicare patients qualify and sign up. And if we have 843 Medicare Part B patients, and we know starting this year, every one of the Part C plans is paying for this right here. And let's say if your practice has half the number of Part Cs as Part Bs, that's about 1,264 Medicare patients. That's 11, and at 80% of those getting the service, that's 1,000 Medicare patients a month getting it. At $17, that's about $17,000 a month net profit, or $206,000 a year. So let's take a look at a summary right here for this particular practice that we looked at. He's not been billing EKGs. That's a small increase. He's not been billing spirometers. He can pick up a spirometer for $700 from McKesson or I just went blank on the other companies out there that's doing them out there. $700 from a GPO plan to do it. He's not been billing for home health agency search and research. There's $16,000. Has not been billing AWVs. There's $28,000 a year net profit. We already showed that. Has not been billing annual wellness visits. That was $213,000. Has not been billing chronic care management. There's another $206,000. What else could I find? I didn't even go into things like 24-hour Holter monitors. A lot of your doctors could be doing those, and 30-day cardiac event monitors. I've been doing those since about 1994. They save lives. I didn't go into the hydrostat breath hydrogen testing. I didn't go into full PFTs. Just a very cursory glance at this particular doctor's information. And we're looking at over $400,000 a year. Now, if you're making 8%, what's $32,000 in your pocket as a billing agency? Now, you also get improved client satisfaction. You get increased income for the client, and you get increased income for your own practice right here if you're on a percentage basis right here. And there's a bonus too. What's the bonus? Whenever billing agencies, and I've got quite a few on my Med Managers listserv, that's the free listserv I've had since 1996, that we've got, I don't know, about 1,200, 1,300 people on it, something like that, and it's free. I've had quite a few people on there that have billing agencies that have had me do this with their clients. And then whatever I make from the client, that net profit, I send 20% to the billing agency as my way of saying thank you. I can do that. That's not a stark problem. It's not a stark problem me paying you because you're not the one ordering this on the patients, the doctor is. So that's why I can give this to the doctor, but I can give it to the billing agency, and so I do this. It may not be that much. Now, what do I charge for doing this for your clients right here? The hour and a half I'll spend with your clients. At the end of the Zoom call I do with your client, if your client believes I just increased their income by at least $10,000 a year, they'll send me a check for $500. Real simple. If they don't believe that I just helped them increase their income by at least $10,000, they don't send me a penny. They don't owe me a penny. I would say easily 9 out of 10 phone calls, I end up getting a whole lot more than the $10,000. My average primary care practice that I do this with sees an average increase of about $170,000 per year. That's $170,000 a year. That's almost $15,000 a month that my clients end up seeing right there from that. So if it's been doing that, and I've been doing this for years, why wouldn't it work with your clients? What do I charge, by the way? If your clients need me to do a full practice analysis, occasionally I'll do this, and I'll figure out, okay, doctor, you need me to do a full analysis. I need to review your progress notes. I want to see if you're going to get in trouble with your billing. I see that you're undercharging. I need to educate you on what the review systems are. I need to educate you on when time plays a major factor because you haven't been documenting time. I need to spend some more time with you because you haven't been billing out critical care or you haven't been billing out this service or that services. I do that a lot. I'd say probably about 1 out of every 5 little mini analysis I do, I recommend the doctors do a full analysis. And it's funny because almost every time I recommend that, the doctors say, yeah. Why? Because that comes with a guarantee too. If I don't make them an extra $50,000, they don't pay me for the analysis. And again, my average is 170. Teaching them what I'm teaching you today, plus a lot more, that I don't have time to go in. I cannot take 30 years of knowledge and cram it down into 90 minutes. So don't think I'm telling you everything right here. On some specialties, I'm going to refer them out to someone who's better at their specialty than I am. Mental health, I'm probably going to recommend to Sean over at Doctors Management. If they're a cardiologist, I'm probably going to refer them to cardiovascular. Thoracic, I'm probably going to refer them to Terry Fletcher. It depends on what their specialty is. Now, I've tried to keep it down to under an hour and a half, and I'm going to open it up for questions right here. But I'm also going to give you guys a gift. You're going to be getting an email with a survey link via email within the next hour. And when you do, if you'll complete that survey right there, I'm going to send you the last 2 issues of my monthly newsletter that doctors subscribe to for $99 a year, which is like $8 a month, $99 a year. And this newsletter, you can copy and paste articles from my newsletter into your own newsletter to your own clients, or send this out to your own clients if you see something in there that's going to help your clients stay out of trouble or increase their income. Also, if you need CEUs for this seminar right here, the way you're going to get it is by completing completing the survey, and in marking, I need CEUs for this association, because there's about 3 associations that I'm able to give you CEUs for, or 2, yeah. So anyway, I have that in the survey. So now then, with that said, I'm going to answer questions for you. Let me go back here and pull up the questions, so forgive me as I'm doing this right here. Will this be available later? Brenda. Brenda, I'm going to be able to teach this at another time for the people that weren't to be able on it. I'm not going to put out a PDF on this right here. I am recording this. I may end up, because I'm getting a lot of requests, I may end up putting this on my website for people to be able to buy for a certain price. I've got to pay my bills too, obviously, because my wife, somehow she expects me to pay bills. I don't know why. Give her money so she can. How can we find this information for Medicare? Katie asked, good question. I take it you're asking about the data information from Medicare, this huge, large files that I'm breaking down into Excel. You can get that and break it down using Access. But even with the maximum RAM that you can put on a laptop, which is what I have right here is my Apple laptop with the maximum RAM, I hit a key and I have to wait for it to go down, because it is over 1 million rows of information and 72 columns of information. That's huge. But you can get this on CMS's website, Katie. And because it's you asking, email me and I'll see if I can get that to help you find it. Will it be available later via email? I won't be able to finish viewing today. She's already gone. Okay. How can we increase income for physical therapy? They bill modalities. Yeah, and you got to be real careful for physical therapy or physiologists, because a lot of salespeople out there selling equipment to doctors, selling the equipment to the doctors, are lying to the doctors and saying, because this one machine right here has electrodes over here and has electrodes over there, and this does electrical stim, and this does re-education of the muscle re-education, and this right here does a 97140, etc. You can build this code for 15 minutes and this code at the same time, and you cannot. I've done a special newsletter on that dating back to 2009, and I even have a free webinar, a 10-minute webinar about billing modalities on my website. It's one of the free webinars, and I did that for an electrical stimulation company that I highly like. How does meaningful use affect billing? I have no idea, and I really don't care, because I've not got jumped into the meaningful use crap, honestly. Anonymous viewer. Anonymous? What are you doing asking me a question and not even giving me your name? That's ridiculous. I don't know. I don't deal with meaningful use. This particular service charge is only valid for PCP. I don't know which one you were asking about, Lisa. I'm assuming it was for annual wellness visits, and annual wellness visits or chronic care management can be done by anybody. Katie asked, what about other specialties? I do this with all specialties. Sometimes I'll come back and tell them, look, here's some free advice right here. I really can't help you to the point where I can increase your income that much. Someone's asking about mental health, dietitians. Again, I would say doctors management, they've got 80 consultants. They're absolutely brilliant people over there at doctors management. Mr. King has done an amazing job. Paul King has done an amazing job on gathering people together, from Frank to Sean to Shannon to, John Bishop does work with them. Just they got some really good consultants for other specialties. Again, the ones that I am best at is going to be your family, internal, and geriatrician. That doesn't mean I'll say no, that I won't do it for the other doctors, but I will do this analysis for your other doctors because you were on the call and you asked me to, and I don't mind. And yes, I can handle podiatry as well, Lisa. I've got podiatry clients. It's been a retainer client of mine since the early 90s down in Lufkin, Texas. They pay me a retainer fee every month. It's one of my retainers. Any other questions right here, folks? Okay. Don, my name is, we're able to see a question in the chat area. Let me see where I can find the chat area. And do not ask me to say your name, because that's a name. Okay. Don't you have to be a certain specialty to bill for depression screening for Medicare patients, i.e. behavioral health versus an MD or DO? No, you do not. There's no specialty requirement on that one right there. What about home health for nurse practitioners? In some states, they can sign, I believe, Diana, they can sign home health search and research. Some states, I believe, they cannot. You'll have to check with your state scope of practice in that. Somebody asked a question right here also about, okay. You apparently, when you do not bill on a curve and only bill the higher level exams, you show that you've reviewed the system, spent face-to-face time. Does that exclude a possible audit? No, you're going to be audited. If you're billing the highest level, if you're billing the highest level, and regardless, you're going to get audited. Now, you may come out smelling like a rose once you get audited. But people that believe, and I'm going to show you right here, I'm going to go ahead and pull up something right here and cancel this right here and show you a spreadsheet I have. People that believe that they can only bill one specific specialty, take a look at one specific code. This is a spreadsheet that I have, that I created, that I've sent out to a lot of folks. And I will send this out to the folks that want this, because then you can use this in your own practice. And I've got it broken down per specialty. And this is actual data. This is not something that Medicare said, 3% bill out this, 11% bill out that, 41%. I took the raw data from Medicare for the 2013, and then I took a large chunk of it and then averaged it out. I paid my assistant, Crystal, who's no longer with me because she decided she liked having summers off, and so she went back to being a school teacher for junior high kids down by Houston. I had her spend time and gather all this data for me, and then I ran all the numbers. So these are the numbers I actually ran. And you'll notice right here for the different specialties. Family physician, for instance, 32% of family physician new patient office visits were billed at level 4, 50% level 3, 4% level 5. If you come back and show 100% of level this, you're going to be audited. The recovery audit contractors have it set up that if you automatically flag for an audit, if you're 10% above the average, and I'm within 2 points of the average on this right here, based on a 2%, 2-point margin. So I know I'm real close right here. Like internal medicine, for instance, 49% level 4. If you're billing out 100% of yours at level 4, you're going to be audited. Now, you may come out smelling like a rose. I'm not saying that being audited is a bad thing, but just you need to make sure your I's are dotted and T's are crossed. I mean, back in 2004, I bought a purple SSR, Super Sport Roadster. I mean, that's got 21-inch tires on the back, 20s on the front. The front end looks like a 52 Chevy. It's convertible. You push a button, the top comes down, and it's got a V8 Corvette engine in this thing right here. So I guarantee you, when I'm going down the highway, every cop around me is sitting to hit me with their radar gun. Now, by the way, when I got back home, my wife took that car away from me because it's purple, and purple's her favorite color. And she does look a lot better in that, her blonde hair in that, than I do. So I went out and bought a big dually truck. So that's what I run around in. And yeah, I know what you're thinking. Little guy, big truck, compensation, don't go there. But I don't mind if they audit. Now, I don't mind if they take my picture. Last time I had a speeding ticket was in 2006, 10 years ago, on the way home from my mother's funeral as I was thinking about something else. It's not like I speed, so they can take my picture all they want. If you're not doing anything wrong, don't let them intimidate you into undercoding. Code the level you're doing, code the level that's medically necessary, but make sure that it's you picking the code and your doctor's picking the code, not their stupid computer system. Their computer systems are going to get doctors in trouble. They are getting doctors, not going to, they are getting doctors in trouble because the computer system are picking codes and almost always they're not assigning the right points towards the medical decision making. So therefore your doctors end up undercoding. And then you got the other doctors through their narcissism or godlike egos. Everybody I do is a level 4 because I walk on water. My name is Gregory House, whatever. Don't give me that BS. Nobody is always a level 4, level 5 in any practice. You're going to have somebody come in that's a minor problem. And maybe the doctor did a high level, but the medical necessity would drive it down. So be careful there. That's why I do a lot of audits. Where do you get the Medicare utilization data? I am paying for it from MGMA. Manny, quit paying for it. I'm going to give this data. I'm going to send this to you, buddy. It's the least I can do after all those neat videos you've made, by the way. Okay, what other questions we have here? That's the chat area. Let me go back to the questions area because I'm bouncing back and forth between chat and questions. And where are my questions? Oh. So you see this data over here. I'll email this to everybody who fills out a survey. This will be the 2013 data. I have not run the numbers on 2014, but I can guarantee you that 2014 is going to be real close to 2013 because doctors really don't change that much. So it'll be within 1 to 2 points of this. This will be good for you until it takes me, I don't know how long because I don't have a crystal anymore. I'm trying to do it all myself before I can run the 2014 data personally. Okay, so where is my questions? Chat area, questions area. I'm trying to get back to it. Okay. Here we go, questions. Can I help podiatrists? Yes, I help podiatrists a lot. I have attempted to explain that this is not, but doctors seem to feel they're usually correct. How far back can they do an audit? Okay, here's your question. Okay, I see it now, Sophie. Safira, okay. How far back can they do an audit? This doctor spends a lot of time documenting and following review of systems. He also lists a systemic disease that the patient's had, feels that this wants a higher level of care, i.e. hypertension, diabetic, blah, blah, blah. He may be okay. Sometimes auditors have surprised me. Have you had a professional consultant take a look at that? That's what I do for a living. I don't mind doing it. There's others out there, depending upon your doctor's specialty, I may refer them. Because like I've said since I opened my company back in '85, that's a long time. If somebody else can do a better job for your client than me, I'm going to refer your client out to them, or my client out to them. That's just the way I am. Sometimes I have a doctor last week called me up. He says, can you help me? I ended up referring him to Jim Zhao because Jim's the best at what he needed, and he was talking about $400,000. And he said, well, will you make any money on this? I said, no, I'm not going to make money on it. I'm going to refer it out to somebody else that can do it better. Okay, Joanne raised a hand. And Jan, if you're still raising a hand, I need you just to type your questions in here because I don't know how to see when people just raise hands. I'm still new to this Zoom thing. I've been using GoToMeeting for years. These are all the questions. I know I've gone an hour and 34 minutes. And if there are any other questions right here, you're always welcome to email me questions. I'm here to try to help you. Please don't call me at night because it bothers my wife as we're sitting here watching TV or having dinner. I try not to take calls, but sometimes I have to. Call me if you need to. Email me. I'm here. It's been an hour and 34 minutes. No other questions are coming across. So I am going to sit there. I sent a question about Indian Health Services. Let me scroll back up here. I must have missed it. Forgive me. Mariana. I don't see the question. Maybe you emailed it to me. If you email me a question, I will email you back. I'll do get back to everybody. I don't see it in the chat area. Wait a minute. Here we go. Do you have any experience with Indian Health Services? I have family clinics, see native and non-native patients, and they have an OMB rate with Medicaid that pays a flat rate for this. So I don't, they don't list the codes. Wow, no, I don't. The only, the only under Indian Health Services, the only experience I have is I am a CASA, Court Appointed Special Advocate, so I have to know all of the Indian Health Services rules regarding ancestry, because I do have to make sure that if we place a child with a non-Indian family, that's Indian, but that's about it. I know that's more information you really want to know, but I'm sorry, I don't really have any information on Indian Health Services or Medicaid. If you'll email me specific questions, I'll put the word out. By the way, speaking of that, if you're not on the listserv, I have 1,200, 1,300 people on my listserv. Send me an email saying I want to be on the Med Manager's listserv, and I'll add you. It's free. We generate a lot of emails a day. And you ask any question on there. If I don't know the answer, somebody else a lot smarter than me out there on the listserv probably has the answer for you. Okay. Yes, that is a real gun behind me. No, I don't carry that gun with me. This is the one that I carry everywhere I go. But that is a real coat up there. Thanks for doing the webinar. You're welcome. Are you familiar with contract health coverage as well as VA coverage reimbursement? No, I really don't know that much about VA. I'm a veteran, 12 years myself in the U.S. Navy, but I don't know that much about VA coverage. I'm sorry. But I tell you, Doctors Management has one person over there. I'm trying to remember his name. He's a consultant, Cooper, I think. That's what he specializes in. So if you ever need to, I can hook you up with Doctors Management out of Knoxville, Tennessee, and send you a referral to them. And no, I don't make money by referring them either. But if that'll help you, that'll help you. Okay, that's all the questions right here. You're very welcome. I see a lot of thank yous. I'm awesome. Thank you. Please tell my wife that. She's having a rough time right now. One of her friends was killed in a car wreck a couple of nights ago. If y'all want to pray, if you believe in prayer, do me a favor and pray for my wife, Angie, because one of her friends just passed away. Y'all have a great day. Thank you so much. You're all a blessing to me. I guarantee you I would not be where I am today after 30 years in this business without you. Whatever I can do to help your clients, please know that I will treat them the same way I treat my own, 100% honesty. And I'll never recommend anything to your client for the money. I'll recommend it to them for their patient care, and money will follow. It almost always does. Thank you so much. I'll say goodbye if I can figure out how. Thank you. And I'll send you an email in the next hour with the survey. So that you can take the survey, and then that way I can get additional information out to you that you're requesting in CEUs and the free newsletters. But please think about scheduling me with your clients. That's how I make my living, and I will definitely help your clients, I promise you. And I will never try to take your clients away. That's what I'm here for, is to help them. Thank you and goodbye. If I can figure out how to say goodbye. Stop video. End meeting. Here we go. End meeting for all.